Good morning and welcome to Medicine Grand Rounds. I'm really excited to introduce our visiting professor who's going to be giving Grand Rounds on a topic that could not be more timely. Dr. I is a graduate of Yale, where she took her psychology degree. She did a clinical fellowship in psychology at Harvard and took her PhD at the University of Vermont in child psychology. She did a postdoctoral fellowship in Burlington and then went down to MUSC, where she was a clinical instructor, and actually that's where she first interacted with the medical university there and started turning from child psychology to the psychology of adults and specifically medical professionals. She took an assistant professorship at the University of Memphis and then went on to become associate professor and director of the Psychological Service Center at Pacific University, prior to her current appointment, where she is professor in the Department of Psychiatry and associate director of the Resident and Faculty Wellness Program at OHSU in Portland. She's published broadly. Looking back at her first ever publication in '91 was indeed about conceptual and developmental issues in children's coping with stress, and her most recent publication is entitled Feasibility of a Comprehensive Wellness and Suicide Prevention Program, a Decade of Caring for Physicians in Training and Practice. She's been supported for her research, currently supported for a grant entitled Reaching Out to Distressed Residents and Faculty, and she's co-investigator on a grant entitled Promoting Resilience in Medical Residents. She's a good citizen nationally and locally, and she's a member of the Committee on Professionalism at OHSU. She's received a number of awards along the way, including Clinical Supervisor of the Year when she was at MUSC, Chief Resident Award for Contribution to Internal Medicine Residents in 2014, and the Pediatric Clinical Staff Team Award for Exemplary Contribution to Resident Education in 2016. I counted 44 public presentations recently throughout the United States, specifically focusing on topics such as the one that she's addressing today. I can't imagine a more timely visit for Dr. I, who's today going to present Medicine Grand Rounds entitled Caring for Burned Out and or Distressed Residents and Faculty Physicians, a Comprehensive Wellness and Suicide Prevention Program for Academic Medical Centers. Please join me in welcoming Dr. I.
Can you all hear me? Great. All right. Good morning. Thank you so much for inviting me to be part of this rounds. I always feel so good when I'm visiting places and learning about what they're doing and hopefully sharing some ideas of what we've been able to do at Oregon Health and Science University. This is my first time coming to Madison. It was really exciting to fly in on Wednesday and look down at the snowy runway. And fortunately, the lady sitting next to me, who was wearing a Badger shirt, said to me, not to worry, we can handle this, no problem. We're used to this type of landing on a snowy runway. But I do feel a bit like I'm coming back to my roots. My grandfather played basketball for University of Wisconsin, probably back in the 20s and 30s. And his name was Otto I, and I was driving in with Dr. Newman the other day and saw Otto's Deli, which kind of was fun. You don't normally see the name Otto, and felt like there were some connections here. So I want to start by talking about, I don't have anything to disclose other than I am fully funded through our graduate medical education program, and that is one of the messages I want to get across here, which is there's no way that I would have been able to, with my colleagues, build the kind of program that we had without the support of our graduate medical education and our OHSU healthcare team. All of our services are fully funded, and that was purposely done to lower the barrier of cost. And I hope that if there are any healthcare leaders in the audience who have access to the budget, I hope that message gets across. So I want to acknowledge there are a number of people who have been part of building this program. In particular, I want to shout out to my colleagues, Mary Moffat, who's the director of our program, Marie Solar, who's our psychiatrist, and Mark Kinsey, who's our senior consultant. And then most of all, I want to acknowledge the many trainees and faculty who have blessed us with their trust in coming to talk with us about their experience and get help. So my objectives would be for you to leave here with a really good understanding about what happens when physicians are distressed, whether they're in training or on faculty or in practice, and what are some of their concerns about coming for professional help. They know about treatment. They hopefully know about good medications to address anxiety and depression and other kinds of psychiatric issues, but they're not getting access to that. Why is that? And what are some strategies that we think can make a difference in terms of promoting help seeking when people get into difficulty? And what are components of a comprehensive program? What do we know from the general literature? So I want to start with a story. I, of course, de-identified anything about this resident, so if you think you know her, you probably don't, because she's sort of a combination of people that I've seen over the years. But she came to see me a number of years ago, and she was a surgery resident in her second year, and she was really struggling, not so much in her residency. She actually reported that she was getting very good evaluations. She really loved the work that she was doing. She found it very meaningful. But she was really struggling with the intensity of the process, the long hours, the kind of work that she was needing to do, and the steep learning curve. And in particular, when she came to see me and made this remark that she thought being suicidal during residency was normal, she was working nights. And she had a young child at home, and her husband was a stay-at-home dad, and things were not going very well. He was pretty down and not happy about how many hours she was working, even though she, had told him that. You never know until you're in it. It's kind of like being a parent for the first time. You don't know it till you're in it, how hard it is. And she would come home and she would try to stay up. After working all night, she would try to stay up to be there for her child and to help support her husband. And she really wasn't doing well. She was getting very depressed. And I felt really sad and concerned when she made this remark that she thought this was the norm. And unfortunately, we know from looking at some of the studies that are being done, looking at depressive symptoms and suicidal ideation, there are a number of medical students and residents who are experiencing suicidal ideation, and physicians in practice. Doesn't mean that it necessarily leads to suicide, but clearly people are in distress. So here's some statistics that unfortunately have been emerging in a number of studies that have been coming out. We know that burnout rates are increasing, that burnout appears to really kick in the third year of medical school. Before then, medical students, there was a great study that was done a couple of years ago, a multi-site study, and I can't remember if Wisconsin was actually part of that study, but there was a great study done by Brezu and her colleagues in which they found that medical students were better adjusted than their colleagues who'd gone on to other careers. But by the third year of medical school, they were reporting a lot more anxiety and depression than their colleagues who were doing other careers. So something starts to happen in medical school, and then we know, unfortunately, that when people get into residency, the long hours, the steep learning curve, the debt, sometimes other interactions that are happening during residency put our residents at risk for burnout. And actually the burnout rate of 50% or higher, that's from physicians who are already in practice. The burnout rates for residents are higher. Depends on the study. Some are 70%. I've seen some studies that have suggested 90%. So that's a significant concern. And then depression rates are also significant, and they are higher than what you see in the general population. Probably overall, the average number seems to be about a third of medical trainees, so medical students and residents are reporting at times clinical levels of depression. And then of greatest concern, I think, to all of us is the suicide risk. So here's an example of what's happening at a national level. And if any of you are interested in learning more about what do we know, what's the research out there, what are policies that are being put in place, what's happening at a federal, state, and programmatic level. I encourage you to sign up for the listserv for the National Academy of Medicine. They have created an action collaborative on clinician well-being and resilience. And this is headed up by the AAMC, the ACGME, the Nursing Association, a number of other groups are partnering. And actually all academic medical centers, and I forgot to look and see if you all have this posted, have been invited to post what their statement is about addressing clinician well-being. So I think 180 healthcare systems and academic medical centers have already posted what their objectives are or aims are to promote clinician well-being. We're in the process of working on putting that up as well. You just submit it online and get that out there. But I encourage you to look at what other institutions are saying their well-being efforts are. But I think this infographic really captures why this is so important. We know that providers that are struggling, that are burned out, are not probably providing the best possible care. They're at greater risk for leaving or cutting back on their FTE. And then I think of greatest concern, their quality of life is greatly impacted. And probably the most serious statistic is the one showing that we lose 400 physicians each year to suicide. Now I want to just take a few minutes just to focus on the whole question about suicide, because I think there's a lot of concern, which is important, but also some confusion. I was just speaking to a group of residents last week about this, and I wanted to just clarify a couple of things. So a paper came out this past year in academic medicine with Tim Brigham and Tom Naska as the authors on it. They're the heads of ACGME, and what they did was they and their colleagues looked at, for the last 14 years, what have been the causes of death for residents in this country. So a really big sample of looking at what are the causes of death. And the number one cause of death for residents was actually surprising to me, and I think maybe to other people. It was neoplasms. The second leading cause of death was suicide. Now, there is a gender difference. For male residents, the leading cause of death is suicide. For female residents, it's neoplasms. And then after that is accidents. And then below that was an extraordinarily high number of accidental poisonings, which the authors wrote they felt concerned might have actually been suicide. But no one was ever able to detect that. So the suicide rate is not increasing, according to their review of the literature, and of all these numbers, it's not increasing among medical trainees. Unfortunately, it's constant. It hasn't changed across the decades in which people have been looking at suicide in trainees and in practicing physicians. It's concerning, the numbers, and I think we've got greater attention on it. There have been some high-profile situations, in which there was a situation a couple of years ago in which 2 internal medicine residents died in New York City, and that really got people very concerned, and a number of articles came out after that. So I think our attention is increasing to this, but it's not that there's suddenly been a big uptick in the suicide rates. So when I think about what do we need to do, there's this tendency, I think, for us to want to focus in on just our population, but I think it's really important that we look more broadly. And there are other populations where we've done suicide prevention and evaluated it in a really effective way. One group that's really done a lot of work in this area is the Air Force. So starting back in the 80s, the Air Force implemented very comprehensive suicide prevention protocols, and they have the ability to make people fill out research questionnaires. You can imagine well, obviously we're in the VA. You all know about how that might work. And so they've actually been able to show that doing comprehensive counseling, suicide prevention efforts does lead to a decrease in suicide rate. It's hard for our individual groups to detect that because there's a low base rate for suicide, but a big population like Air Force recruits, for the last 10 years, you can start to detect that. Another group where we've done really good evaluation of best practices in suicide prevention is with college students. So university counseling centers across the country collaborate in collecting data and having initiatives, and they have done a lot of work in this area as well. So one group that I draw from a lot is the Suicide Prevention Resource Center. They have a listing of all sorts of best practices across different populations. Excuse me. And this is a wonderful model that they've put together. And the JED Foundation is also another great group that does a lot of work on suicide prevention in young adults. And they've captured here, what do we know are best practices? And I just encourage you to look at this and think about, where does your institution fall on this? What is it that you're doing well? How are you doing in terms of promoting social connection? How well have you trained each other, and especially people in leadership roles, to be good at recognizing when people are in distress and knowing what to say and how to encourage them to get help? There was a wonderful video that the Mayo Clinic and the American Foundation for Suicide Prevention put out last year called Making the Difference. And it's residents speaking directly into the camera in a very powerful way about how to talk to another resident who's distressed and maybe suicidal. What are we doing in terms of our messages around help seeking? Are we really giving our residents and our faculty permission to take care of themselves? And then the area where I focus a lot on is, what do we have available for people to access? Are they getting access to the best possible mental health services? And then, very importantly, what are our crisis management resources that we have in place? Do we have 24-hour call when somebody is in crisis? What kind of teams do we have in place when something tragic and unexpected happens? Do we have a postvention plan if there is a sudden death, perhaps even due to a suicide? What do we do to reach the other people who may be now at risk? And are we doing things to restrict access to potentially lethal means? For example, in my institution, we had a couple of years ago a tragic situation actually at the VA where a patient killed himself by jumping off of the roof, and because the stairwell wasn't locked. And so those stairwells are locked now as a way of trying to restrict access to lethal means. So what are we doing? And then finally, what are we doing to help people manage stress, communicate well, resolve conflict well? Those are important parts of this comprehensive approach. So let's shift now from talking about, if those are the best practices, what happens when we try to apply this to our family, to our medical trainees and our faculty and providers in the community? So this was a comment that I heard when I was doing some surveys with residents and fellows about how they felt about coming for counseling if they were in distress. And this fellow wrote in through this anonymous survey, I feel embarrassed to be depressed even though I know I shouldn't. The thought of friends or even my coworkers or patients finding out that I came for counseling is terrifying. So an example of someone really worrying a lot about stigma. Another faculty physician early on in career commented that they were very concerned about if their counseling records would be in the hospital electronic health record, and they never would have come. This was actually a faculty member that I was working with, and she told me at the end of her working with me, you know, I never would have come to see you if I knew my records were in EPIC, which is our electronic health record, because our records are not within EPIC. And another big concern that we know exists for physicians is worrying about reportability. Now, residents don't seem to be quite as attuned to this, but faculty sure are, and physicians in practice. And so we talk a lot in our educational outreach workshops, and when we meet with people individually, we talk with them about this. And there is an effort nationally by the Federation for State Medical Boards to really encourage state medical boards to change their wording. Now, they can't control what state medical boards do. The legislators put the wording in there about what they want to be addressed. But we know that this is a concern for physicians. And these two studies that came out recently highlight that. Kathleen Gold, who's done some really wonderful research, I think she's at Michigan, looked at a Facebook group that's a closed group for women physicians. And she got them to fill out some surveys on mental health experiences that they've had. And it was concerning that a number of them reported that they had had some kind of mental health issue. but only 6% reported it on their licensing application. And the majority of them said that concern about whether their medical board would ask a lot of questions, require additional evaluations, maybe even take away their license if they told them that they had a problem with depression, that kept them from getting help in some situations. And that's what we all worry about. We worry about people going underground because they're worried it could impact their credentialing or their licensure. And another study that just came out this past year from Lottie Derby, who's at Mayo, looked at wording for state medical licensure applications all across the country and found that a number of the states were still asking about mental health condition. So ideally, what the Federation for State Medical Boards and a number of us who are working in this area are calling state medical boards to do is change the wording. That certainly we don't want to have providers out there providing care and having those providers be impaired. We recognize that we need to look out for that, and we need to make sure that that doesn't happen, that people get treatment. But what we do in Oregon is our medical board asks, have you ever been impaired? And if you've been impaired, you need to show that you're now fit for duty through an evaluation. We don't ask, have you ever had a mental health problem? Have you ever had counseling? Because that doesn't necessarily mean that you're impaired. So that's a hope that I have that things will happen at a national level. I didn't get a chance to check whether or not Wisconsin has wording about impairment versus asking about illness or treatment. Does anybody know? Nobody knows? All right, that would be good to find out, because it would be good to get the word out. What is the situation for Wisconsin? So to summarize, these are the common barriers that you see in a number of studies of medical trainees and physicians in practice that people worried about. They're worried about confidentiality. A lot of people are worried about, is there going to be time to access counseling? I'm already so busy. I've had some people tell me, I don't know how this is going to be helpful. What's making me upset are the long hours, or that my attending is on me all the time, or where I've got all this debt. How is coming to talk to you going to be helpful? People are worried about stigma, especially people who are really concerned about the amount of debt they have. Medical trainees, they're worried about cost, about co-pays, deductibles, and then, of course, reporting or disclosure concerns. So you can see there are a lot of factors in why physicians do not get help. So what are the treatment models that might help people get the counseling that they need or medication that they need, and hopefully lower some of these barriers? So when we've looked at what are the different models out there, one certainly is to try to provide people with a list of providers maybe outside the community that they could see, that they would typically use their insurance to see. And what's good about that is that they're separate from the institution, so there may be more confidentiality. The challenge, though, is if any of you've tried to do this, even just sometimes trying to find a good primary care provider can be difficult. It's really hard in many places to find a good prescriber and to find a good talk therapist who's going to have the hours that work, especially for residents. It's really unusual that a very experienced psychiatrist or psychologist or social worker is going to have hours late in the evening or on Saturdays. And certainly there's going to be the financial aspect of co-pays. And you have to have a diagnosis in order to use your insurance, something that some physicians don't like, that idea. Another solution are employee assistance plans, or EAPs. And I understand here that your residents and faculty can access an employee assistance plan. It usually involves calling an 800 number. It's usually contracted by the institution. And these are usually counselors out in the community that you can see typically for like 3 sessions. It might be longer than that, depends on your plan. And then if you need more counseling than that, then you're referred on. So that's helpful in that you can typically get in pretty quickly. They may have a lot of flexibility in hours. But one thing that we hear from physicians is they wonder, will these counselors really understand our experience? And is 3 sessions enough? Probably not, especially if we're dealing with clinical depression or anxiety. And so we may lose people. They may not do very well in being referred on. So there's some challenges with that. Then, of course, there are programs that are embedded, that are in-house, that I'm going to be describing in more detail. And then there are support groups that can really make a difference. And I understand in the pediatric program, they have started something called Lavender, which is an opportunity, I think, for residents to process their experience. There are Ballant groups, there are Schwartz rounds, reflective opportunities that can really make a difference. And then finally, another area that's emerging that I think is important to think about as part of a menu of resources are online tools. And not Richardson, I'm forgetting his first name, but Sen, who's also at Michigan, and his colleagues just published in the past year a really good article with medicine interns that they started to track as soon as they arrived for their internship. They had them filling out measures of depression and even suicidal ideation. And then half of them were randomly assigned to maybe get some educational materials, and the other half were enrolled in this online CBT tool called Mood Gym. And then they tracked these residents over the year, and what they found was that the residents who were depressed and even suicidal who participated in this online Mood Gym reported much lower levels of depressive symptoms and suicidal ideation versus the control group. So that's another tool that may be emerging that's helpful too. So our program, what we did, is unfortunately these sort of things often emerge when something bad happens. And so back in 2003 or 2004, we had a tragic event in which we had a resident die from suicide. And people were very upset about this. There were also some changes happening in terms of where residents were going to get their health care. And the residents were being told, you're going to need to get your health care outside of the student health center, and also your counseling. You need to go out into the community. And the residents were not happy about this. They said, we're not going to have time for this. And now you're telling us we got to go find somebody in the community. And we had a leader at the time, an associate dean of graduate medical education, Dr. Don Gerard, who had been doing a lot of work in the area of wellness. And he was able to talk the hospital into giving us a little money to start a wellness program. And we did, and that's one of the key things, is you can start small, and then you just show that it works, and you just keep asking for more and more money, and the next thing you know, you've got a big program. At least that's how we do things in Oregon. Maybe you all start boldly and just go ahead and get that big money, but it often seems like you got to start small. And what we did was a couple of us signed on. My colleague Mary Moffat, who's in the middle, and I came on. And one of the things we did was we decided that we were going to be separate. Even though we have appointments in the Department of Psychiatry, we're not involved in teaching and evaluating residents. And that's a really important point, because I know a lot of academic medical centers are trying to figure out where do we pull in these providers if we're going to build a program like this. And of course the Department of Psychiatry would be a logical place to start. But it's a tricky thing because residents do not necessarily want to see a provider that they might be working with a week or two later in the ED or calling a consult, and then that person is standing there, and they just did some therapy with them the week before. That's really hard. So it helps ideally to have your clinical team be separate from faculty who are training and evaluating residents. So a couple of things about our model. As psychologists, I'm always thinking about what do we know are effective treatments. And one thing that's really important, this is taken from the clinical psychology literature about what treatment works. What are factors that contribute to adults improving significantly in treatment? And I won't go over all the details, but this is the amount of change that happens in treatment when people get good therapy. And one of the things that jumps out, of course, is 30% of change that happens. And these are studies involving hundreds and hundreds of patients. These are very sophisticated meta-analyses that people have done looking at who improves on standard measures and who doesn't. And so 30% of the change that happens when people get treatment, when they go for counseling, is related to whether they have a good relationship with their therapist, which I think argues for continuity of care and having therapists who are really experienced, who get what the experience is like for residents and faculty. The technique that you do is about 15% of change. Also, extra therapeutic factors can be what's happening in your work environment or your family that's having some kind of role. Another key factor that's been emerging in the psychotherapy literature is dose. And for those of you in medicine, you probably understand this well in terms of antibiotics. I often talk when I'm meeting with residents about how when I first start working with them, it's going to be like a Z-pack. We're going to start off kind of intensely. I'm going to hit them hard because I want them to feel better. I want to address the anxiety or the depression or other issues that are going on. We're going to meet a little bit more regularly. And then as they start to do better, I'm not going to let go of them. I'm going to hold on to them for a little while, and we might meet like just once every 3 weeks or once a month, and I'm going to stay involved, and I say, like a primary care doctor. We're going to do some booster sessions to make sure that you're doing well. And that's really important because when people have had something as significant as a clinical depression, you can't just see them a couple times and then they're good to go. You've got to stay with them. And so our residents can come back and see us all throughout their training. We don't have any limit on sessions, and the same thing for our faculty. And so I've actually had the pleasure of working with people all throughout their training, and then they've stayed on as faculty, and I get to see what they're doing. So we do briefer interventions. We're not doing intensive weekly therapy because we don't have the capacity for that. And really, I don't think, especially residents, they don't have the capacity to do that kind of intensive work typically. But what we offer, I think, is pretty helpful and hopefully getting the adequate dose. So what is our menu of resources? That's a key theme here is that, one size does not fit all. So we focus on individual counseling and coaching. And by coaching, I mean we often work with people that are not clinically depressed or anxious, but are coming because they're feeling a bit lost about something in their career. I see a lot of people that are trying to decide about, should I apply to fellowship? Should I take this job? I'm dealing with something in their personal life that they're struggling with. I see a lot of early career and mid-career faculty who just want some coaching about a situation. I've even worked with some faculty leaders who have just needed somewhere safe and confidential to come and talk about some of the things that they're dealing with in the role that they're in as a leader. So that's where the coaching comes in. We also have a psychiatrist that is devoted to working with our program. She comes in from a community private practice 2 days a week, and she does evaluation and medication management. That's really important because it's very hard for physicians, at least in Oregon. I don't know how it is in Wisconsin, but it could be true as well. It's hard to get access to a psychiatrist that you can get in quickly. We get our people in quickly. And she's able to stay with them and provide telephone consultation so that, if they get pulled into a surgical case and have to cancel their meeting with her, they can email her and she can say, yes, I think you're doing fine on the dose, or address a question, you're good to go, and they are able to stay on medication. And she's made the point that a lot of these people would not have stayed on medication and got the treatment they need if they didn't have the kind of flexibility that our program offers. We also do a lot of coordination of care. We're not able to see everybody in terms of providing specialized care, and so when somebody needs specialized care, maybe around significant substance issues or eating disorders, or perhaps if they need stepped-up care, they need to have a partial hospitalization or a hospitalization, our program stays involved kind of like you all do in that we facilitate the referral, we help support the program director, or if it's a faculty member, their chair, and help them return to work and coordinate them getting what they need in order to get back up to speed. As I said, we do a lot of consultation, and we also do suicide prevention screening, and I'll talk more about that shortly. And finally, we put in place a peer support program in the past year, and this was based on Joe Shapiro's model of helping physicians after they have an adverse event. So we helped create that and trained some of the faculty and residents who do outreach to physicians after an adverse event. So some crucial decisions that we made were on site, but we're not right next to human resources, which is where they wanted to initially put us. Somehow, it's always funny when the space committee gets together. That's a very powerful group. And we had to explain, no, this would not be a good idea for faculty to have to walk right past the head of HR's office to come in and see us. So we're in a private area, but we're on campus so that people can get to us quickly. As I mentioned, we're not involved in training. This is free, so there's no insurance billing and there's no co-pays. By the way, our program initially started in 2004 for residents and fellows. By 2008, the faculty were agitating to be able to come to our program. They would come up to us after our workshops and they'd say, you know, we're not doing very well. We could really use this program too. And so we went to the hospital leadership and we said, hey, can we expand this to the faculty? And they said, those faculty can use their insurance to go, somewhere. And we said, no, they say they're having trouble finding good therapists and psychiatrists too, and they'd like to come see us. Well, why don't we charge the faculty? And we said, well, why don't we just not charge them? So we must have gotten lucky that day because some healthcare administrator said, all right. And so we picked up in 2008 all of the clinical faculty in the School of Medicine. Now, I cannot get to the bottom of exactly how many we have. I get different numbers depending on who I talk to in leadership. But right now, it's somewhere between 1,400 to 2,000 faculty are eligible to come to our program. And that number, the number of faculty that we see is increased every single year. And I had one faculty member tell me, this is the best benefit that this institution ever gave us. And I've heard from some of the heads of HR that this program is helping them because they can now tell people about this when they're distressed. And it really has made a difference. So we've not had any more fussing about let's charge the faculty. We explained that this program does not store their records in our hospital electronic health record. We have a separate encrypted database that we built that's HIPAA compliant. We talk with people a lot about the limits of confidentiality, and we really try to educate people about this reportability issue because it scares, especially the faculty. Some of the residents know about it. The other thing we do is we don't have a gatekeeper. People just email us directly, which is kind of astonishing. We always get these very sweet emails. I'm so sorry. I hope this is okay, but your website said to contact you directly. Is there a scheduler I should go through? No. And every year the hospital says, don't you want a scheduler? And we say no. Because guess what? Residents might be willing to do it, but department chairs, program directors, they don't want to go through a scheduler saying, hey, I'm not doing well. That might be somebody that they're going to work with later on. They email us directly, and it's confidential. We have a secure email process, and that is one more way that we reduce the barrier. And we make it very personalized, and we try to get back to people within a day or so with times. And another thing that we really try to do is we try to tell lots of stories of hope. When we go out to do outreach, we tell stories about people who've benefited from coming for help. And what we hear probably most significantly is that people are telling each other about how this made a difference. So what have we found? Let me talk about what the data is. So we're still trying to figure out whether this works. I'm in the process, as your chair said, I'm the PI on a project in which we're looking at treatment outcomes, and I'm just starting to dive into that data. But a couple years ago, what I did do was I looked at attitudes about help seeking. And I sent out an anonymous survey, and amazingly 70% of the residents filled it out. I don't know if we'd get that number now. I think people are so tired of surveys. But then we had a good response rate from all of our residents anonymously, and we said, if you needed help, would you come to our program? And the majority of residents said yes. 41% said they'd be very likely, 45% said somewhat likely. Now we still have some group holding out, the 12%. I'm curious what the deal is with that group that said not at all, but maybe they go get support elsewhere. But we thought that that was a good sign. And we also asked about what are the barriers. We knew from the literature these are common barriers, and we said, are these barriers still in place? And we were really encouraged with these responses here because actually this is much lower than you see in other studies of help-seeking attitudes among medical trainees that have been published out there. So typically what you see in other studies is like 90% of the people are worried about confidentiality and stigma. I think we've dealt with that. 20% of our trainees said they're not that worried about confidentiality. The 20% are saying that they would be concerned about that, so that means 80% are actually feeling pretty comfortable about what we've been saying. They're not as worried about reportability or about will it help. The number one barrier is still time. And I think that's probably true everywhere. People are so concerned. I just got an email last night from one of the chief residents saying, you know, we love what you're doing. Our residents really appreciate it. They're still saying it's hard to come in and see you because even though we tell them it's okay to go, they're worried about burdening their team. Can you help us with our messaging? So I think people are still worried about whether they can take a break. By the way, there was an interesting gender effect here. How many of you think the men were particularly concerned about taking a break? These are male residents. How many of you would say it was male residents? Okay, I see one hand. How many of you think it was the female residents who were worried? Oh, I couldn't fool you all. Yep, it was the female residents. And also there was a primary care difference here too. So we divided them primary care versus non-primary care. And primary care residents were particularly concerned about taking a break. Now, when I tell the surgical people this, they get quite annoyed. They're like, well, we would be worried about that too. And I said, well, I don't know, but the primary care people are worried about taking a break, and the women residents. What about will not help? How many of you think that the female residents were worried that it will not help? How many were thinking male residents were worried it will not help? Yeah, this audience is very savvy. Yep. It was the male residents. So that's really helped us in terms of messaging. When we go out to do outreach, we tell stories about male residents who've benefited from counseling so that we can get them to come in. Here's an example of a comment, that I thought was pretty funny in terms of, the italics that this person had written on one of our surveys, that it would be really hard for surgical residents to come see the counselor unless you have a senior directly, and they put that all in caps, above you who's okay with it. And that they would feel pressured and couldn't leave the service for an hour. And so, even though we've built this program, we still have residents who say they're not sure if it's okay to come. And so one of the things I encourage you all to think about is make sure that if you're a senior resident or a chief or an attending, make it clear, especially to your junior residents, that this is okay, that you're supposed to seek care. If your tooth is bothering you, go see the dentist. If you're not feeling well, go see your primary care provider. If you're feeling stressed, go see a counselor. Because those messages really do have a big impact. So we know that at a national level, that we have requirements in place now from ACGME. This came out this past summer, the new common program requirements that apply to all residency programs. And this was a very significant change from what they had before. And interestingly, the chair of the committee that came up with this wording is our chair of psychiatry, Dr. George Keepers. And he admitted to me that he based this on our program. So he and the people at ACGME who pushed this through are saying that all residency programs, when they go through site visits, are going to need to document how it is that they're making mental health treatment accessible. It needs to be accessible, and it needs to be affordable. And also, we need to have access to emergency care. So one of the ways that we've dealt with access is we talk with people a lot about how do you come and see us. We do this through orientation. We encourage people to have informal messages about it. We try to have a range of hours. We start seeing people at 8 in the morning, and some of our last appointments are at 6 at night. We are on call. One of us is always on call to deal with urgent issues. And people come and see us over a range of times. Some people see us post-call. They probably don't remember anything we say. I feel like I'm just sort of tucking them into bed. I say a few things and I say, why don't you go on home now? But often that's when people will come, or they come during didactics. We also have quarterly wellness half days, which might be a time that people would come. But most of the time, they come because they're able to just duck away, or they've got a really nice senior who says, yeah, go to your meeting or whatever you need. And what's interesting is certain programs, it has become so acceptable to go to the wellness program that people just announce it. Oh, I'm going to the wellness program. I just find that amazing because, I mean, that's just great. We've kind of broken down the barriers. I would say two of the groups that are the best at that are pediatrics and medicine at OHSU, and I hope that's true here. And as I mentioned, we've had faculty express that this program has really meant a lot to them. I've had faculty come to see me who are on the verge of quitting, and, well, this will be my last parting shot. I'll come in and talk to you about it. And I've said, okay, and we've talked about it, and some of them have ended up leaving our institution, and some of them have ended up making changes so that they wanted to stay. And I still see them around, and it's wonderful. So what has happened in terms of our visits? I'll just end very briefly with a little bit of data, but I'm not going to spend much time on it. As you can just see here, our number of visits have gone up dramatically, and the number of cases we're seeing close to 200 residents a year. And we had a little bit of a drop there. 2013 and 14, we had a big surge. That was when we rolled out our suicide prevention effort. We put in place the interactive screening protocol, which is an anonymous online screening tool that the American Foundation for Suicide Prevention created, and we contract with them to do. I don't think that's something that you all have in place, but I would encourage you to look at it. It's considered a best practice for suicide prevention. And so we rolled it out there. We did workshops in almost every single residency group, and we saw a big increase in our numbers. We dropped the next year, and I think that's because we got moved. The Space Committee decided to move us from a more centralized location near the hospital to another 5-minute further away walk in an even more private location. And that 10-minute walk, the residents told us, was hard because then they were even further away from their clinical duties. So the location, the access is really key. We're slowly rebuilding, but that was a factor. Here's just a little sense of what we're doing with faculty in terms of their cases. So about 2/3 of our caseload are residents and fellows, 1/3 are faculty. So we saw over 100 faculty last year, and you can see the visits and numbers are going up pretty steadily for faculty as they find out about our program. And then finally, just in terms of kind of a little bit of data on where we're at, I think it's helpful to look at how does this compare in terms of what percentage of residents come and see us each year. So when we first started, we saw about 5% of all residents that year, and as we're ending, we're averaging about 23% of residents and fellows for the entire institution come to see us each year. We think that is pretty significant. And I don't think it's just because of our weather, though our weather is depressing, all that rain and gray. I think it's because people feel like this is accessible and is helpful. And one comparison, so up there for faculty, about 6 to 8% of faculty come to see us each year. The EAP is something that's available to all residents and faculty and staff. They see about 6% of employees. We don't know if they're residents or faculty. I doubt many residents are going to the EAP. University of Washington has a really good counseling program, and they published a paper last year reporting about 14% of all their residents and fellows come each year. University counseling centers report about 10% of students come each year, and then for the U.S. adult population, about 13%. So you can see we are much higher than you typically see when adult populations and in similar programs. And I think it's because people know about us and they see it as relevant and helpful. So I know we don't have time to go into all this, because I want to allow time for questions. I will be happy to talk in more detail about who comes to see us, but as I mentioned, here's a breakdown of who we're seeing. I want to just jump ahead to, in terms of, we've already talked a little bit about help seeking and how important that is. Let's see, I just wanted to jump ahead here. So I want to just kind of close, though, with this model, which I think is really nice, that was published back in 2017. And it just might be something for you to be thinking about as you're evaluating where your wellness programming is. I think primary prevention, obviously, is very important. And I have a sense that you may be ahead of us in terms of that. I'm hearing about you participating in some neat wellness surveys as part of a multi-site collaboration at Stanford. It sounds like you've got some really good support groups that you're in the process of developing. I think it's very important that we be working on training our program leadership to be good at screening and intervening with at-risk residents and faculty. And then tertiary treatment is obviously the part where I've focused the most in this talk on providing really good, high-quality treatment to allow people to recover after experiencing significant distress. There's some wonderful resources out there that are coming out that besides the National Academy of Medicine. I would encourage you to look at the Collaborative for Health and Renewal in Medicine, CHARM. They are publicizing a number of good resources out there. ACGME has also put out some resources that I think are helpful to look at what can we all be doing better in this category. And then I mentioned the online screening tool, the interactive screening protocol, that is really helpful. What's important about that, though, is you have to have a clinical team that is set up to respond to the surveys as they come in. So I provide an individualized response to residents or faculty who fill out this survey, usually within 24 hours, and I give them feedback on how they scored on this measure, and then I encourage them to come in if they're reporting high levels of distress or suicide risk. And once again, just to highlight how important it is for all of us to have in place a good emergency plan. You know, who's on call, what's your protocol if somebody is in great distress, and of course, you know, if a tragic event occurs, do you have a crisis response team in place? And I mean, it's kind of sad to say, but ACGME and the American Foundation for Suicide Prevention have a really good toolkit that all program directors should have, and that's after a resident suicide, a toolkit for program directors. So if you haven't looked at it, you probably should look at it. Make sure that you have in place a good plan, because when those things happen, things move very, very fast, and you need to make sure that you're looking out for other at-risk trainees and faculty. So in closing, what this costs, as I mentioned, this is all funded through our healthcare system, and it represents 1% of the GME budget, and it mostly is made up of our salaries. That's really what it costs. So if you want to figure out what it costs, you know, figure out what it would mean to bring on mental health professionals and have them work with your trainees and your faculty. And our FTE right now is 2.25 FTE, and we're able to take care of we cover over 2,000 physicians. But we're at capacity, so we're bringing on some more people. All right, so let me open it up to questions now.
Thank you very much, Dr. I. I'll ask you to call on the audience and please repeat the question.
Okay. Yes, the lady in the back. Oh, sorry, the lady right there with the lovely tan blazer.
I'm Nancy Raymond. I'm really enjoying SFPH last June as they sort of conduct 8 years ago, and I'm also a faculty in the Department of Psychiatry. So I have 2 questions, and I'm really glad at the end you put up the slide about the 3 levels of care.
Yes.
Because harkening back to something you said at the beginning, when medical students come in with higher levels of mental health than peers, and 4 years later end up with lower levels of mental health, it's not a problem of the individuals we're bringing into the system.
Yeah.
And I think it is critical when we're looking at burnout in students, residents, and faculty to
Thank you very much for clarifying that. Wonderful comments. All right, so I may not get them all summarized properly, but you were making a really valid point that we need to be looking closely at what's happening in our curriculum and in our system, that our medical students are starting off well-adjusted, and then after a couple of years are reporting a lot more distress. So we need to be thinking very much about preventive interventions in UME and graduate medical education, and I absolutely agree. And I'm trying to learn more about how to do that. I've been focusing so much on the tertiary care, but my heart is now very much turning to looking further upstream. You were asking a very good specific question, though, about what do we do if we have a physician who's impaired. I'm so glad you asked that because I didn't clarify that very well. So we make really clear in our outreach and also when we meet with people individually, what our limits of confidentiality are. And they're, the usual ones. If somebody is abusing children, we're going to need to report that. And they all yeah, we know that. If we say if you're acutely suicidal or homicidal and we cannot keep you safe, we can't contract for safety and keep you safe in an outpatient setting, we're going to break confidentiality. Then the other thing we say to them is, unlike a community therapist, because we're an in-house program, if we think you're either impaired due to cognitive issues, severe psychiatric issues, or substance issues, we're going to break confidentiality. And we're going to inform your chair or division head or your program director, if they're a resident, that you need to take a medical leave of absence. We won't say why, but we'll say you need to take a medical leave. And we will then facilitate them getting specialized assessment and intervention. And in the case of substance use, we're going to refer them to one of the best people in Portland, a psychiatrist who works closely with the medical board for a fitness for duty evaluation, and they may end up being enrolled in the health professions program, which is a state medical board program that monitors, doesn't provide treatment. But we get them into that and we help them make the report themselves. We encourage them, we even sit with them as they call the health professions program. What we might do, though, first is we might have them see this really top expert in the community first for an evaluation, and then help with the reporting at that point. So, yes, thank you for clarifying about that. But we have had physicians, this is one of the stories we tell, who have been impaired, who have gone for intensive inpatient treatment, and who have been able to show they're fit for duty, get their license back, come back, and finish their training. And we try to get that word out, too. We don't want to lose those people. Physicians respond so well to treatment. Yes?
Have there been studies of large enough cohorts of suicidal physicians to look in sort of a retrospective psychoanalysis of predictors of high likelihood of suicide, such as coincident outside stressors, such as failing in your residency program, such as financial risk, that somebody who's trying to help somebody like this would say, this is a problem. We've got to really pull out all the stops.
Yes, that's a really good point. So have there been studies looking at what are the risk factors for physicians who have actually killed themselves? Have people looked back? And yes, there are people who have looked back on that. There have also been some very powerful books that have been written. One that I encourage you to read is by Mike Myers that came out this past year. He's a wonderful psychiatrist at SUNY who wrote a book after he went and interviewed all these families who had a physician die due to suicide, and he breaks down kind of their stories and what are the key factors. So I think it's called When Doctors Die from Suicide. Not the best title, but it's a really beautiful and important book. So yes, that has been looked at, and it's very much, as you said, it's often the perfect storm of events. It's often a relationship breakup. Maybe if they have a health issue, if they're an older physician, they may be getting critical feedback. They've had a bad event. They're getting depressed. But probably the most critical factor is that people who kill themselves, 90% of the time, have untreated mental health or substance issues. And so that's why the best thing we can do in terms of suicide prevention is get people good treatment. And probably the most telling thing was Kathleen Gold's study, in which she went in and looked at the causes of death for physicians who had killed themselves. And the physicians who had died from suicide, a lot of them had they had benzos and tricyclic depressants in their system, which is not the gold standard for treatment. They weren't even on SSRIs. So I think they weren't getting treatment.
I
Thank
hope
you.
we can continue this perhaps at the end of the session. I want to thank Dr. I for giving just an outstanding grand rounds. I also want to mention that we have leaders from the department, from the school, and from UW Health here.
Oh, good.
So your message is being heard broadly, and we really appreciate your being with us today. Thank you.
Thank you so much. Thank you.
That was outstanding.